Good morning, everybody here and at home. So what I was going to do today would be talk about Huntington disease. I realized that we haven't heard much about this condition here, as far as I can recall, since my arrival. And rather than before going to the future, I thought maybe we can anchor it more, give you update of state of the art, what's happening now, which is but of course there's a lot of excitement going on, like exciting news, and also our center will be also part of the several important trials, upcoming trials. So I will probably focus more on the present, kind of probably second part will be, of course, the future. So what is the Huntington's is a relatively straightforward disease in terms of genetics. It's a monogenic disorder, so there is only one gene. There is actually Huntington's disease like two gene, which this patient is actually Parkinsonian, as a matter of fact. There are very few conditions. I will not spend much time about a differential diagnosis like SCA17, and because again, genetic testing changed everything. And I remember when I was a resident, which kind of like it's last century. It kind of sounds bad. Before the gene was available as a testing, so there were different criteria, radiologic, and so on and so forth. So you had to put your thinking head on. So here it's just basically genetic testing, and I first ruled it in or ruled it out. Somebody comes with the chorea, and of course, in appropriate context, and not like I don't think would be drug induced, even though as I test, you just test for HD, and then if it's negative, then you put your thinking head on. So I won't spend much time about chorea differential diagnosis, but as you see, this is a prototypical disorder. Gene is on chromosome, showdown of chromosome 4 with the CAG repeats, which is exon 1. And so if you look at it really follows a lot of other CAG repeat disorders. Most of them probably would be spinal ataxias. That would be probably the most important group, other group of CAG conditions. And it was realized that the pathogenesis is really there's no point mutation known ever, in this gene. And so, of course, normal would be 26 and less. So we all have 16 or 18. 16 between 16 and 18 is the usual number in a wild population. So one thing I would point out, if you do genetic testing and it comes as a homozygous, because obviously you have two alleles. So if patient is, let's say, 16 and 16, there is one theoretical consideration that the other expansion wasn't detected. It was so large. So, people in the past, we used to do southern blots, or now there are different in the vicinity, different polymorphisms, so you can kind of really make sure that you are getting both alleles sequenced. But anyway, so the cutoff is actually now 36, even though for a lot of trials we will talk about that is cutoff 40, which basically, so about 40, which is the sort of what is maroon or whatever is the color, that's like 100%. You still have a variability, and that number of repeats would determine variability by about 50% of the, so the radius penetrance is about 36 to 39. So that means that you may escape. As a matter of fact, I had this kind of small cluster of patients, really in their 60s, who had this about 38 or 39 repeats, and they came to me, and they told me, basically paraphrasing or quoting, I cannot have a Huntington disease because I'm too old. Of course, they had Huntington disease and there were 40 plus first degree relatives exposed or being, at risk. I would like to also spend some time about intermediate allele, which basically is important. So it's basically 27 to 35. I've seen two patients, I recall, who had clearly signs of Parkinson's, Huntington disease, and had an intermediate allele. So what is important for the genetic counseling is that if somebody inherited that there is a chance for further expansion. So this is sort of unstable So they are prone during the meiosis. It's more important for male meiosis. So there are a few conditions where there's a significant difference between male and female meiosis in terms of propensity to expand. Actually, looking at Dr. Brown, so there is one important, there is a maternal transmission. So there is one condition when if it's inherited from mother, it can be devastating. So which one is that? No, Angelman is different. Angelman is either point mutation, deletion, or loss of imprinting. But it's a doctor. It would probably Dr. Brown would be seeing the patient. Well, but actually, no. Actually, would be going to Norton myotonic dystrophy. So myotonic dystrophy is actually a good example. Again, I'm not trying to digress. When you have inheritance from mother, so this I'm just kind of giving you these examples that's important. So of course, going back to Huntington disease, is that this is mostly if it's inherited from father, so you may see expansion. And so that brings us to the concept of genetic anticipation, which is an important phenomenon, which you should remember. That means that it can be not only expansion, but at early age of onset, and also more aggressive course of disease. If it comes about 56 alleles, there is it's called juvenile Huntington disease. So these patients have a so-called Westphal type of the disease, which actually they are Parkinsonian. So I mean, I have a few juvenile patients who really have a chorea, but you have to be, because if you see them, they may be really looking Parkinsonian. So you have to really thinking about these things. And I would also point out that Huntington disease is a true dominant disease because obviously there are very few homozygous. So basically, there are some conditions which are autosomal dominant, but they are lethal in dominant setting. If a patient would have both alleles. And so actually, there was it's part of Venezuela. Forgot the name of the lake. There was a big community and really inbred. And so these patients who are homozygous look basically the same. So it's very different from other type of mutations where, if there is a true dominant disease, they would be lethal. But again, just kind of really giving you idea that think about it. And again, for the juvenile disease, you may have a Parkinsonian symptoms. So what is the epidemiology? So we have about 25,000 rather patients with the manifesting HD. But basically if you look at the number of patients who are a priori at risk, again, the risk would be 50%. So it's, it behaves in a dominant fashion. And there are about 2/3 of carriers who are at risk. So again, mean age of onset is about 30s. Again, we talked about the correlation between the number of repeats and age of onset. It's 5 to 10, 100,000. So it's not rare disease. I mean, so obviously it doesn't have a connotation because it's 2,000 people, so, but it's something what you will see if you don't have very specialized practice, just epilepsy only or so on and so forth. So these patients are out there. So the gene frequency is higher than clinical disease, 2.5, 3 times higher, which kind of really implies a lot of these patients are undiagnosed or misdiagnosed, which is kind of important and will be kind of interesting to see. We'll see more genetic testing with the sort of new information. Or again, I will probably cut this in 2 parts and talk more future later on. But again, let me go through the talk. And again, it's lethal. These patients, I would usually say 15 years, of course, but they can survive. But it's very bad disease. It really robs you of all your faculties, which are going to go through symptoms in a minute. Again, so going back to that, so I already mentioned that there is this kind of correlation between age of onset. Do I have African American patient? No, we have a lot of SCA3s for obvious reasons, but I don't recall any patient. Well, I have one patient, I think. But again, and basically, again, so this is kind of really more recapitulation of the previous slide, kind of just giving you, kind of really driving the message home that this is not a rare disorder. So again, diagnosis, I keep this slide for kind of sentimental reasons, I guess. So, this, the skeleton was, of course, done some time ago. But really, if you look at the, laboratory, with the asterisks, it's really DNA test. It's really genetic testing. So again, you may sort of, again, there were some interesting radiologic criteria. I will show you some pictures soon. The issue of biomarkers, I don't think they have a much role for we'll talk about it in details as a diagnosis. But again, this is the condition. You basically you either have Huntington disease and then go from there, or you don't have it. And then, of course, let me, as I said before, put my thinking hat on and figure out what's the cause of your chorea. Actually, I have a few patients who look like HD, they're negative, and it's very difficult sometimes to detect. But that's really what you do first. Again, MRI, of course, and we will kind of I'll show you specific features. But again, this is kind of more, of course, family history. But again, about 25% patients don't have unknown family history. So I kind of told you that story of the lady who was told she cannot have a Huntington disease because she's old. But of course, forgot to also say second half of the story that she didn't have a family history and could be consistent with that reduced penetrance, in this. It was about 38 repeats, if I remember correctly. Again, prognosis is pretty bad. Usually the cause of death is they are bedridden. I stopped seeing these patients, so they just, no, they don't disappear, of course, but most of them go to Indiana to a few nursing homes. And so we used to have privileges and kind of really just doesn't work. So it's kind of sad because I would like to see these patients, but again, it's tragic. This is actually, I have a patient who, that was a long time ago, who told me this is the worst disease in the world. Of course, it's macabre conversation. What's the worst disease worst to me, ALS and brain tumors. But basically the reason he said that is that you live long enough to sort of see you going down the hill and you give it to your kids. So again, obviously, and that's kind of really reflecting that important sort of burden of the families. And unfortunately, because there's a lot of problems, as we will hear about in a minute, in terms of behavioral problems, cognitive problems. So many times see these families really generational poor through generations, because obviously it's hard. No, there are a few rich people. They don't come to our clinic, unfortunately, and they don't gain money. But it's really it's a really very devastating disease, which has a really lot of different consequences. So when you kind of think about it, I kind of talk about it as a 3 M's. If you want to have some mnemonic, think about 3 M's. So motor symptoms, of course, that's clear M. So behavior, of course, I say mood. Of course, it's much more than mood, but I'm really just trying to simplify it. So it's, of course, affective illness. We talk about risk of suicide, obsessive, compulsive personality. These people are really irritable, kind of unpleasant to be around. There is impulsivity leads to very high suicide rate. And these patients are really sometimes difficult to be around. So actually I had a clinic yesterday, even though it was pleasant. But it's really kind of if you think about it, it's really a neuropsychiatric cognition. And last M, of course, so I call it memory, even though it's actually incorrect, but it just kind of it works that 3 M's work. It's a cognitive symptoms. Actually, it's that classic, what we used to call, kind of call it less so subcortical dementia or frontal lobe syndrome. I still think it's a very valid concept, but it's kind of, but again, would be cognitive symptoms, which I think they're most disabling. If, obviously they are all bad, but, we can talk about psychiatric symptoms relatively treatable, and I will talk about medications for chorea, but again, cognitive symptoms are probably most important. And so patients who don't have a known family history usually present with the chorea, which is the most common in 90%, even though now we are much more tuned in. I'll go through staging in a minute. Tune this kind of, used to be called pre-symptomatic or pre-manifesting stage of the disease when they have a certain decline. So chorea can be manifesting symptoms. But again, I think that's kind of the caveat that it's mostly when these patients are not really aware of the disease. My favorite, again, giving you sort of some anecdotes, we were doing predictive testing, was still at Vanderbilt. It was a mother who was a sort of widow. Her husband was deceased and had a Huntington disease, and they had 5 children. So all 6 of them came. So mother and her 5 kids. And they were all, of course, adults, and they were all, quote unquote, asymptomatic or pre-symptomatic. And they decided to do this family session, and they all were seeking predictive testing, which is one of the things we can do that. That if the patient, before they develop symptoms, they can be tested if the family history is known. But anyway, she went, he has it, she has it, she doesn't have it. Anyway, so she went, was three had it, two didn't have it, and she was 100% correct. So the reason I say that if you are well tuned, there are some very early behavioral issues, personality changes, and again, I mean, but again, it was three had it, two didn't, and she was 100% correct. So again, but chorea, going back to the cardinal symptoms, chorea is not the only symptom. Of course, there could be sort of Parkinsonism, dystonia, especially subtle dystonia, myoclonus, gait disorder. Actually, there's no movement disorder talk without videos, so we'll see some videos in a minute. Again, cognitive, as I said, executive dysfunction, kind of think about that kind of frontal lobe. And psychiatric, of course, we talk about mood, but also there's a lot of personality changes, aggressive behavior. I had two patients who threatened to kill me. And then, in sentence, I would kill you. And then, of course, oh, no, I love him. I wouldn't kill him, So which one I go by? And of course, over psychosis. So if you go to my favorite third floor, favorite in quotes, third floor, you may see sometimes these patients, and they may have very subtle symptoms. Of course, many times they would given antipsychotics, so develop quote unquote subtle extrapyramidal syndrome, which I don't like to call it that way. And now everybody thinks maybe it's the disease, it's the medication-induced problem, but again, it could be Huntington disease. And so you will ask about suicide in family that never. But also like very, very suspicious death, like single passenger car accidents out of the blue and things like that, which of course we can be proven that they're suicide, but many times they are. So as I said, it's kind of really, chorea is kind of more from as you've probably heard it many times, Greek word dance. And again, so this is something actually was treatable, and again, we'll go through the details in a minute. But this is the hallmark. Actually, sometimes it goes to Huntington's chorea, even though it's more Huntington's disease because of those really more prominent other domains. So again, but this can be sometimes there's a spectrum. So there's I'm not some medical school programs have these like very distinct ballism, choreatotosis. It's a spectrum. I mean, of course, if you have hemiballism, you can usually think about something else. But I mean, these movements that we will see in a minute can be really quite obvious and generalized. Sometimes can be very sort of stark with usually fingers or toes. That's why I actually like to have some videos. These patients, videos kept their shoes on. I like to take their shoes and socks off. It can be kind of really sometimes like almost like piano playing. But again, it's random and purposeless, so again, tics are, purposeful, they are suppressible. Tardive dyskinesia, which is, something what it's important to distinguish, is very stereotypical. So of course, also you need to go by the medication exposure, but also can, many times these patients may have you may be thinking about Tourette's when they kind of make sort of vocalization. Could be if the chorea affects actually even the diaphragmatic muscle, which can be very difficult to treat. And again, it's the randomness is very important. Again, comparing to the stereotypical tardive dyskinesia, even though sometimes it cannot be, and sometimes I would just do the testing. Just really, as I said, rather than just kind of observe, you just do testing. I expect to be negative, but it's important to really just close the chapter because obviously treatment, and most importantly, the treatment, as a matter of fact, would be similar at this point, but the prognosis is very different. So, now, of course, it's kind of how does it sort of matter? So, again, there's definitely substantial evidence for impact on day-to-day functioning, and there is definitely significant contribution to disability. And again, one also thing I really had a lot of interest was the falls, related to the chorea. There is definitely increased risk, and thus the treatment is not only cosmetic. Now it changed, but some of these videos are from Netherlands. So they have a very good program, but they would be like not treating this chorea like they kind of almost they changed. But you can see this. I have this some videos really. They just wouldn't consider that as important, just kind of feature of the patient. And again, so this is kind of more in data evidence of employment. Of course, it's important. Actually, we have one patient who is NP from Eastern Kentucky. So obviously I think it's my main concern. Of course, is cognitive, and he has two lawyers, which kind of is a nightmare, who have also really, and it's kind of more behavioral issues because. And so, but again, but also if there are, jerky movements, actually, it's very conspicuous and can really affect the, well, do you know the Scheherazada's saga, stories of 1001 Night? So this will be kind of probably what will happen. This will be kind of, it won't be 1000 talks, but of course, kind of realize that we'll probably split it. But I think it's good to know because HD again has been on the front page, even news, BBC, and of course, other major outlets of the media, also in the States as well. But this is relatively new data, and it's interesting that the patients are in the green, and many times this chorea can be more. This is kind of data from 2012. I'm not sure why the reference don't show up. So it's many times that chorea is more, it drives crazy the caregivers, even though so patients are really rightly so bothered by the executive dysfunction, which I think really that's to me it's the tragedy of the disease, and actually we have really no treatment for that, and of course the other issues, of course, but chorea was most commonly sort of pointed out by caregivers, but of course you also want to treat patients. But again, I showed some data that also makes sense in terms of not only sense, but also has benefits. And similar idea or impact on different ADLs, looking sort of these patients who do have chorea have a much higher burden of the disease. So this is a gentleman who, you look at him, again, I wouldn't mind that his shoes and socks are off, and he would be like sitting on a bed and his kind of feet hanging freely. That's I like to do that. This is actually, I got this from our trial for one of the medications. I was the video reviewer, and sort of kind of see this kind of sometimes look at this, sometimes his kind of feet would go. It looks more like it can look almost like fidgety, and so there is you see more sort of trunk movements when he is doing different these maneuvers. And so his gait is relatively okay. So you see very subtle, but again, you can sort of think somebody's maybe quote unquote fidgety, as I said. Still, it's not really wide-based. We won't see, I think, a tandem, but he may have a slight problems on tandem, but subtle. So that's very important. So of course, this is anything but subtle. And also would point out, patient's weight. Of course, I don't know her weight, but you really can clearly see. So, this is a really bad way to lose weight. Of course, there are some other issues, but of course, you see very generalized, trunk, generalized chorea of, almost like dystonic posturing of legs. And and again, this is basically all the time she's awake. So I was going to talk about weight loss rather. Many times I see weight gain when I treat this chorea effectively. So actually I like to it's almost like one of my biomarker, if you will. And also I want to show you her gait. Well, if you were not really well tuned, you would kind of think about John Cleese and Ministry of Silly Walks or a psychogenic patient, so you have to be very careful. Sometimes can be so quote unquote flamboyant or nearly bizarre. The most bizarre gait is, by the way, I think with a neuroacanthocytosis, when they look like John Cleese. And everybody knows John Cleese. Mandatory viewing, Ministry of Silly Walks. I had a poster in my clinic in Vanderbilt, but I was forced to take it down. So there is a way to assess chorea, very, very sort of semi-quantitative. So this is the part of from the our UHDRS, which is basically unified, Huntington disease rating scale, which is mostly for chorea and of course extracranial movements, which are sort of most low saccades. I haven't talked about it, and of course some dystonia. I mentioned falls, and you saw that lady, the second, I mean, there was only one lady we saw. So the lady, looking at her, kind of really also leaning backwards. So there is definitely very important. And again, it's not everything is chorea, but I think chorea definitely, it's kind of hard to walk when you're really swaying all over the place. A lot of these patients kind of walk like, it was like, you see this kind of leaning backwards. It's one of the few, it's almost like they either had a STN DBS surgery. Of course, you would know the story. So you see these axial problems, when you did STN surgery for Parkinson's disease, or they have Huntington disease. So of course, you have to be more, but it's almost like you can make a diagnosis, I have this mysterious disease, people, I don't know what, you have Huntington disease, you can say it in 2 seconds, not just maybe 5 seconds, of course, you still need to do your diligence stuff for the billing, but it's a different story. So treatment, and again, really positive therapy or will be disease modifying therapy. That will be, of course, that's really what is it about. But again, before we dive into that, I thought it would be better to anchor this, to the state of the art what we have now, because they can kind of, so that will be this kind of another story of the Scheherazade. But really, basically there are the only domain which is not really treatable in the symptomatic fashion is unfortunately cognitive symptoms. So I stopped doing, sometimes I do an amenda, but it just kind of, it's just that nothing works for that degree of cognitive problems. And of course, and again, the causative or maybe disease modifying therapies, of course, that will be, not sure we'll probably have enough time today, but again, I think this would be very ripe for the second talk as a sort of series. Anyway, so you probably all heard about VMAT2 inhibitors, especially in my clinic. So actually, there are now 3 medications available. Tetrabenazine is really the mother compound, which was actually developed in 1947 for schizophrenia and didn't work for schizophrenia, was kind of forgotten. I trained, actually, I mentioned last century. So I trained University of Michigan, and which is, of course, in Ann Arbor, those of you know. And and of course, Canada is very close. So way before tetrabenazine was available in the States, we would send patients to, again, the only question, do you take the bridge or do you take the tunnel to go to Windsor and get the medication? So it comes with the black box warning because it really stems from the original tetrabenazine trials where I think 2 suicides, and actually you also need to, tetrabenazine is a very, very difficult metabolization. Actually would be almost like you can spend half an hour talking about it. There are actually 4 metabolites: alpha plus, alpha minus, beta 1, beta plus, beta minus. So alpha plus is really the most effective, and it's also more selective for dopamine depletion. The other ones may have other monoamines, of course, would be serotonin, norepinephrine, and histamine. So histamine is important because these patients may be very sleepy. And if you overtreat these patients, kind of think about it, you can induce Parkinsonism. Again, black box warning is only tetrabenazine. It actually was based on tetrabenazine study, but it was kind of labeled as a class. And it's interesting, for instance, that Austedo and Ingrezza have dual indication also for tardive dyskinesia. So the black box warning only applies to the HD part, so it's kind of confusing. I really don't care. I mean, of course, I do care, but I'm not like that obsessed with that. Sometimes, with this marketing, black box warning and so. But you have to be very careful. It's a great medication, but so how does it work? It's really depleting, as I said, it's presynaptically depleting dopamine. Again, so that's the most, so you basically release, so kind of if you think about chorea, it's too much dopamine in the wrong place, wrong time. And again, if you overtreat, I had a patients who are induced Parkinsonism, it's almost like inevitable, but it's very reversible. I kind of threw away slides just for sake of time, showing basically improvement, but it's about 5-6 points of the UHDRS, and it's very reversible. You stop the medication, comes back right away. Again, so VMAT2 tetrabenazine again, or again, so didn't tell you. So Austedo is deuterated tetrabenazine. So in deuterium is, of course, as you know, non-radioactive isotope of hydrogen, which has a one extra neutron, and of course, the tritium is something what Oppenheimer would use in the past. And so which of course is very radioactive. And so we have about 2-3 maybe percent of deuterium in our body, so because of a lot of hydrogen, hydrogen. And when so basically they were trying to deuterate, so using instead of deuterium, instead of regular hydrogen, different molecules, and they were just throwing them through the sort of really different assays, and it really made metabolization of tetrabenazine less volatile. So Austedo actually can be used twice a day and has really less hydroxylation. Again, I don't want to talk much about medications. That could be some maybe other talk for the other settings. And valbenazine, which is Ingrezza, is a prodrug which goes to alpha plus tetrabenazine. But again, tetrabenazine is still the mother drug, as I said. That's the compound which was all developed, as I said, in 1947. And other monoamines, of course, would be serotonin, and again, I think depression. So this is contraindicated. Patient is actively depressed, but you can treat that. You can combine that with the other antidepressants. Really using garden variety of antidepressants. I don't have any sort of specific for the psychiatric problems. But again, this is working presynaptically. What do you know? Do you know example of VMAT1 inhibitor? Pharmacology in 101. VMAT1. Have you heard about medication for high blood pressure and people would jump over the roof because of suicide? It's a horrible depression, I mean. Which one was there? Was there one medication? Nobody's used anymore. Reserpine. So reserpine is a VMAT1 inhibitor, so which is important because VMAT1 is actually distributed throughout the body. So again, it's all, again, I obviously like history, and it just really gives you more, so that's why I encourage you to kind of understand still pharmacology, molecular biology. We'll talk about, really, we'll go to molecular level very soon. But so reserpine was example of VMAT1 inhibitor, of course, and it was much less selective. Of course, so of course there is a hypotension, which is not the issue with a VMAT2 because they are only in the brain. So that norepinephrine, but again, can be more the mood. And again, histamine is interesting that and either these patients either have insomnia or they are sleepy. So it's very interesting. About 30% have insomnia if they have a side effect from the sleep, and 70% are very sleepy. And we think it has to do with the histamine, but we just cannot figure out why. What is the sort of polymorphism which people would be prone to, react differently. But this is something what you can, just watch for depression. You just basically need to monitor these patients, and this will give you an idea of not a chorea, but see what medication can do. So again, this is I would call it kind of more moderate. Again, a lot of trunking shoulders. We'll see his also orofacial kind of puckering the lips. Also looking at the frontalis muscle. So those are all features of chorea. So chorea is not only this, but also looking at the facial kind of, not grimacing, and so also had a little bit of bradykinesia here when you look at him. But there's he's slightly distracted, chorea maybe, but so it's not really much suppressible, even though this patient's showing more suppressibility, I would see. Again, swaying kind of, really this kind of almost interesting posture when he walks, kind of looks like, like this kind of flamboyant walking, and you can still see some little bit of finger or in the chorea. And again, this is just an example of what we can do. This is actually a patient on Ingrezza, really looks normal. We can sort of play it, for sake of time, not the whole thing. And it looks basically for practical purposes normal. So this is going to be extremely. I thought this is a very good video to show you the really, very useful benefits for the medication. So this is off-label now. Of course, we can also use neuroleptics again. So it's mostly DTU, D as a Delaware. dopaminergic receptors. Of course, that's how antipsychotics typically work, actually D2, D3, most of them. So I don't really have much use for clozapine or even Seroquel, which are so atypical neuroleptics, but they can be used for Parkinson's disease. So I have this rule: if the medication can be used for Parkinson's disease, it's relatively useless for Huntington disease. So actually, my favorite atypical is abiprazole at this point. Still use haloperidol. Some of these patients don't have any, Medicare still makes, no, Medicaid still makes me to use haloperidol, which can work quite well. I've never seen tardive dyskinesia in patients with Huntington disease. Sometimes can be very challenging. Also risperidone. And of course, I use them usually if either patient cannot tolerate tetrabenazine or related compounds, actually mostly now Ingrezza and now Stedo, or most importantly, when they have a very prominent psychiatric problems. So you can sort of use, can cover two bases with one medication, and you can combine them. Of course, you will get this, you have to click on a epic, a nausea, that warning that kind of doesn't, or pharmacy can call you, like, like, why you combine them, like, always tell them if you see unusual combination of medications, of course, there can be a possibility this person doesn't know what he or she is doing, but there is a much better possibility that the person is an expert. That's why you go. But of course, I don't say it, don't try to be arrogant, but it's okay to be arrogant if you can back it up by your skills and knowledge. Sometimes you can use amantadine, so it doesn't really work, but of course it would be neuroleptics or VMAT2. Again, I mentioned cognitive problems, and again, there's really no cognitive symptomatic benefits, but really just showing you idea of the very early decline and this kind of looking at these things about complex tasks. Taxes, they're complicated, but of course, it's not rocket science. Managing finances, of course, there are also issues with impulsivity, impulsive buying, driving, and so you can really get. So this is kind of idea how early, and again, these symptoms we kind of more tune in. They can precede even more symptoms. I said that chorea is really 90% presenting symptom, but if you kind of really have this, if they present to clinic, that's usually the case. But patients from the families and in large kindreds, we have many times they come earlier nowadays, kind of shifting that sort of paradigm. They are much more tuned into this, functional problems. And again, this is what really, as I said, most tragic component of the disease, in my opinion, and because it's A, devastating, and B, really not treatable. I mean, medications for Alzheimer's disease. Psychiatric problems, that's a very treatable. Again, I already mentioned neuroleptics, a lot of, so apathy, you have to be careful with the stimulants because they can aggravate chorea, but a lot of problems also would be mood stabilizing, like Lamictal, this patient. So I do really like pretend I'm a psychiatrist. Of course, we have a psychiatric backup if you need to. Of course, we use them, but many times would be for the acute. But of course, Depakote can work, Lamictal can work quite well, and even actually lithium. Some of these patients have almost like obsessive compulsive behavior, and so there is really not much kind of a magic medication. There is nothing approved by FDA. So kind of really, of course, but you don't treat Huntington disease. You treat depression, which is associated with the Huntington disease. But there is no any kind of evidence that something would be. I know these patients take polypharmacy again, but I would emphasize rational polypharmacy. Depression, of course, again, it's very high, actually 40%. It's really more. It's more in disease biology than, of course, being depressive. Huntington disease, of course, that's a bad news, but it's kind of more. It's deeper than that. And again, SSRIs, and actually, I still sometimes used to use, tricyclics, even though you have to be careful about the anticholinergic side effects, especially amitriptyline. But I found them, low dose adding to SSRIs really do quite well. But this is all off label and kind of anecdotal. Again, suicidality is a very big problem. It's about 10%, numbers here, but so it's about more than 10 times higher in the general population. It's a combination of depression and impulsivity. Actually, I would argue it's more impulsivity. So of course, patients are depressed, but also very impulsive, and so you have to really monitor these patients. Always ask about the guns. at home, and again, car accidents, again, many times it's suspicious, people can fall asleep, do fall asleep, but and again, I already mentioned, of course, there's a lot of substance abuse. Actually, alcohol is probably matter of past. I mean, actually, I always get educated when I'm on service about new drugs of the day. We have the status of epilepticus patients. But again, so there is definitely a lot of this psychopathology, and I didn't have a suicide. I had my patient had a one attempt. She was in coma for 5 days. Now she's fine. Didn't have a suicide, successful suicide, a complete suicide last 5 years. So again, knocking on the wood, but again, you have to be very, very vigilant about that. Again, behavioral therapy. I mean, I have it sort of, please other sort of colleagues of neuropsychology, but again, the support groups are very important. These patients are very well organized, actually. So we have a center of excellence, Huntington Disease Association of America, and actually they are really. I don't think there is any better group or better organized. This is meant in an absolutely positive way. Meant in a positive way. So they are very strong advocates, and it's really a privilege to work with these support groups. So unmet needs, again, of course, obviously this is something. So of course, disease modifying therapies, and again, we will have to. I'll keep you in suspense. What's going on maybe in a few weeks. But I still would argue that there is still room for symptomatic therapies, and again, cognitive. I could have said it. I think I'm saying this third time, but I still think that, of course, there is a billions with a B dollars investment going on into there is a big race into, and we'll have actually upcoming trial for the oral medication rather than intraparenchymal or intrathecal injections, which actually I was doing last thing before I came to U of L. But of course, really neuroprotection. But before we go there, let's talk about staging of the disease, because this is very important. ISS is relatively new. I think this is the reference is kind of not sure why it didn't show up. 2024, not 14, 24. So basically, let me start. So stage 3 with these patients are symptomatic. So a lot of things you've heard about these patients are stage 3. So at the time, the old classification would talk about, stage 1 of the disease, based on the older classification, which still has a good meaning. But you see, but basically, and as you heard, this is a genetic condition. So these patients are born like this. And so there is a sort of evidence that there may be some biomarker, we'll go through that in a minute, changes which can really alert you, and actually we kind of use them now in a very sophisticated way. It's mostly a research tool, but again, will be guidance for these new therapies. And stage 2 is basically patients which were basically late manifesting. We talked about, I showed a slide about early cognitive problems, like this task, somebody's like, I have those two lawyers, they are injury lawyers, of course, but still, personally, I still treat them same way, even though they're personal injury lawyers. I like them. I mean, everybody has to have a job. But obviously, so that's a good example of that MP I mentioned before, because that's a job where obviously you have versus somebody has a relatively regular job, not many in any arrogant way, of course, but so that's a sort of, so basically, and that's kind of, there are some sort of single digit modalities test, Stroop test, you can match color and the name and the color. So that's basically the frontal lobe. So Stroop test and single digit modalities that are probably the most sensitive bedside testing. And of course, plus would be total functional capacity. So total functional capacity goes from 13, which is normal. So 13, 12 would be when you kind of, I can do it. Sometimes I feel like I have a capacity of 12 when I have a patient I cannot figure out, but it's still probably 13, I hope. But this is a sort of new. So it used to be that when I read older notes in our clinic before I took over in our HD clinic, the patient has this family history. No, patient has Huntington disease. Patient, you are born. Of course, one thing I want to point out that we don't test kids. So it's actually, I've seen that happening. It's it's not illegal, but I mean, it's kind of malpractice and nobody, there is no consequence. But even for predictive testing, I didn't mention much that about patient has to be age of majority. It's kind of interesting dilemma now because we will have this is modifying therapy. So are we going to move this, into the age of minority or, to minors? I mean, we will see. But again, you can really sort of, so again, these patients really have a, you know, disease. They have Huntington disease, even though they are non-manifesting. You can, if you use this ISS classification, so if you stay stage 1, it's clear these patients are still doing quite well, even though there may be some sort of first signs of something is going on. And again, so you see it. So again, so this is actually this. So I chose this slide on purpose. Actually, going still, sometimes it's better to have a concept. So ISS is important. This is new classification, but I thought this actually show you to better, give you this anchoring when we talk about stage 1. So it's pre-symptomatic and prodromal. So that's actually stage 1 and stage 2. But again, I think so. What you see, and there is definitely some change. Subtle chorea, but cognitive impairment. And of course, there is a certain criteria, and it's very fluid, So actually, doing trial, basically, patients to be crossing stage 2 and 3, and it's a little bit of the eye of beholder. So this is not black and white, and so it's kind of interesting that so it's a judgment call, and it's very arbitrary, So this is kind of, so obviously still wouldn't change the clinical management, but you see that there's kind of brewing things, and again. But again, you don't have to really tiptoe, into puzzle. Is it Huntington disease or not? Yes, it's Huntington disease. You can maybe, have some thoughts. Is it stage 1 or stage 2 already, or 3? But again, it's Huntington disease from the get-go. And so this is actually plotting of different. So TMS is a total motor score. So again, that will be. So you see, also important, with the age, and again, kind of reminding to all of us that. It's more dependent on quite dependent on the number of repeats, and also TFC, which is total functional capacity, which is this kind of purple. They take some time, so until you really until the patient falls off the cliff, they can kind of hang over like 12. So again, 13 is normal, and about 9 is when the patients have really they cannot work. So if they stay total functional capacity of 9, they cannot work. We tell them like give up the driving. These patients on disability. So there is definitely this kind of, so these patients feel, and it's kind of really many times a judgment call, family support, and the type of the job there. Again, let me skip this for sake of time, kind of really showing, so, but again, sort of, again, there is definitely something brewing very early, but let me skip this for sake of time. And let me think where I will stop. So anyway, so let me talk about, so we don't have again. So when you talk symptomatic treatment, would be kind of really when you have this kind of maybe really like horses out of the barn. So actually, kind of works well in Kentucky. So you want to really treat the disease and this is a really. Let me spend some time on this. Important for the concept of disease modifying therapies as well. Do you have any SOD1 patients you treat, or like? Are they symptomatic? So let's say ALS. We know SOD1, of course, has a treatment now. So you may even treat it. So again, treat. You don't want to wait until somebody's like struggling getting BiPAP. I'm just like I said, going into ALS. Same thing for Parkinson's disease actually. So we are going to have a study which is a very early on. So the idea is that so if you kind of look from left to right, you want to really like nip it in the bud. Again, I don't want to keep throwing cliches at you or phrases at you, but I think it really kind of conveys nicely the concept that you really want to intervene. There is a certain time when it's way too late for disease modifying therapy. As a matter of fact, there's one patient of mine who is very kind of moderately affected, still has some insights, and he heard about Unicure and he said he wouldn't be candidate anyway, but like I wouldn't like to be kept in this stage for any time longer. I want to just basically keep progressing and forget about things being demented. Of course, he said it'd be differently, but is the idea, is it kind of really almost ethical or unethical to keep them in sort of this very symptomatic disease? Again, it's a very interesting dilemma, which probably would deserve 1 hour talk itself. But the idea is to really kind of try to really course, for the trial's sake, you have to have some sort of something to guide you that it can they cannot run trial for 10 years. That would be impossible. But the idea, so this is actually, I think it would apply this kind of concept to every condition at all. And let me go through biomarkers and we'll stop there. So this is kind of idea of you're looking at the upper row. In the past, when you do MRI, or you see this really like a loss of head of the caudate nucleus, this frontal lobe enlargement. But of course, you see this also on the sort of setting of sort of evolving atrophy, especially maybe like 35, 40 years old. But basically, this is a very complicated slide, but showing you that how we can quantify. So this is a research tool. You can measure putaminal volume and other things, and this is kind of emerging biomarker in imaging here. The other one, of course, would be biomarkers of the different level of neurodegeneration. I still think that NFL, which is this steepest curve, is probably the best. Actually, the increase in NFL is about 10 picograms per milliliter per year of the disease. In Huntington disease, of course, first time, I'm really disappointed when I try to order NFL in Epic. I guess all this nonsense, so it's kind of sad, though. Of course, MS is probably the most. MS has been sort of pioneering field within neurology. So NFL, neurofilament light chain, is very specific, and I think that there are some other, but I think that NFL is emerging as a winner in terms of biomarkers. But again, think about it as a CRP. So when we have a patient we suspect autoimmune problem, maybe a CRP of 55, it doesn't tell you what is going on, but you have to pay attention. So something similar. So same thing would be for Parkinson's disease. Same thing would be, as a matter of fact, SOD1 mutation was a medication. Tomifersen was actually approved based on NFL data alone. Kind of going back to just giving kind of really going into the arena of neurodegeneration, which kind of really have to think about. We have this kind of different subspecialties, but I like to kind of see myself as a guy who likes neurodegeneration. Of course, there are different causes. If it still would be, we can still be like cognitive, but if there is a lot of overlap, actually, this would be a good example showing you how this is overlapping. So again, so these are sort of biomarkers to help you not to diagnose the disease, but to monitor the disease. But let me stop here. I have a lot of, but so we'll kind of make it in Scheherazade. So I saved my life. Wouldn't be decapitated this morning. So let me stop here because again, this is I wanted to do this even though I talk mostly updates, but before we go to updates, I thought really would be good to anchor, giving you sort of like a refresher in a course. And again, we have a center of excellence, so now I run it. So your residents can of course do rotate, and I think that you should all leave with a decent exposure to HD management, even though you don't do that. But it's really, you kind of will have to remember that from psychiatry. And so let me stop here. But of course, the whole point, as I discussed, is, and this will be sort of second half of the talk, would be this neuroprotective or disease modifying therapies. And as I said, also we are starting, hopefully, this spring, which actually will be oral medication. So there is a lot of buzz, but it's really very well supported. But again, let's keep this as a part 2. Thank you very much, and I can take any questions. And I remember which slide I finished, and we'll go from there. This perfect transition. Okay, thank you very much. And if any questions, I'll be happy to try to address them. Pardon? Oh yes, absolutely, absolutely yes. So again, this is the whole talk, but basically the next slide. So what we think is happening to really simplify, it's a toxic gain of function. So if you kind of if you really want to be very simplifying things, when you think about mechanism of disease, mutation? Is it the gain of function or toxic gain of function versus the loss of function? So CAG repeats are almost exclusively gain of function, toxic gain of function. And a lot of, so this is a splice modifier which would introduce pseudo intron into the mRNA, and it will basically lead to a nonsense mediated decay. So you basically, again, this will be whole hour talk, but it's important to say that this is going to be non-selective, because if you can kind of one big problem we have is the targeting of both selective, mutant form, because every patient, other than those who are inbred, have two alleles, wild type of the protein and the mutant part. So this will be oral medication, which is a splice modifier, which will introduce basically an intronic sequence, which would lead to premature codon stop and lowering about 30% HTT reduction. Of course, uniQure is actually adeno-associated virus 5, and that's also very exciting. That's a lot of news. And of course, I have a data about ASO, which is antacids, but we covered. But this is actually oral medication once a day, 10 milligrams. Quite safe. I mean, if there's a question of if it cause polyneuropathy, it's interesting because HTT, you go non-selective, even though we have to kind of really be very vigilant, about polyneuropathy. Interestingly enough, because of the because you're also suppressing the wild type, but this is a splice modifier, which actually it's called PTC 518, and now Novartis has kind of taken over, because those are billion-dollar investments. Maybe okay, 400 million. It's very cheap. So, but again, those are sort of So again, this is not for small companies, and that's why these giants. So this will be supported by Novartis, and again, this is all public domain data. I'm sorry. Question. So I have a few patients with the chorea. I've done 2 DBS for Huntington disease, and with this chorea, I couldn't stop with nothing. Haldol 50 milligrams. I didn't misspeak. 50. Yes, so it's a Hail Mary type of situation. You can target GPI first. It's important because GPI is atrophic. So, but I've done 2, and actually I have one patient with the chorea, which is probably non-HD chorea. So you can suppress it by GPI, but it's a really, again, I have 2 cases under my belt doing this 26 years. But a great question. So those are. Again, So again, obviously, I presented, important sort of framework reference for treatment of chorea. In the vast majority of patients, very effective, but you have these outliers. Again, my highest dose of Haldol I used was 80 milligrams, 80. I was getting, still Michigan. It doesn't matter. A long time ago, and I was getting these, messages like, "Are you crazy?" from pharmacies. Again, it was built up. I mean, it wasn't, and it worked, but I was like cringing when I was writing prescriptions. What am I? But it worked, so it gives you idea that, some of these patients are extremely resistant. I mean, I would be dead in 80 milligrams of. Oh, I'm sorry. Hold on. Where did you? That's a great question. So that's a great question, and again, it's probably not newborn screening, even though. So the problem is that we have medications which are at this point non-selective. So we are suppressing both wild type and mutant form. The problem is that I again didn't show you the slides. Again, I apologize because it's too much information. That HTT or normal function has very important during the development, and actually, if you do knock out in animal model during the embryogenesis, it's lethal. So the problem would be that when you treat, if I treat these patients, in developing brain, you may really impair their development. So this is a great question, and I don't think we will go, even though SMA is a good example that changed changed the whole thing. but properly not. But it's a very good question, and we need to go. I don't know what's this. We don't know what's the safest time to start. This knockdown protein, unless you have a selective type. There's only one product which is kind of a ASO by wave. But you cannot do LPs every month, starting at age 2 till that it doesn't work. So this is a great question, but I talk about it. We'll be kind of maybe testing maybe minors, but what is the age? I don't know. But stay tuned. And again, this is maybe maybe going that route. Again, kind of anybody knows the movie Gattaca? So that's like for geneticists, it has to be like a must-see movie. So, but I don't mean to discriminate. No, of course, it's about discrimination. It's very dystopian. But anyway, so getting this, we would never see these patients like as a movement is especially, you would never see manifesting HD patient ever, maybe in 20, 30 years because we'll catch it, but has to be then, of course, so one thing we can do would be screening for NFL. You would go to the doctor and it's like having screening for cholesterol, you will also get NFL. Again, NFL doesn't tell you what is going on, but then of course, NFL is high, you have to go to specialists and we have so that may be a better way to detect that rather than neonatal screening, even though that's again, excellent question. Any more questions? Okay. Okay, so again, I kind of anticipated this, and again, as I said, I wanted to kind of anchor you the present and of course the future. So stay tuned, and that will begin. This is kind of so to be continued.